Very good evening, everyone. And again, it gives me immense pleasure to welcome you all for this very interesting, I would say, topic of today on Diabetes Byte on behalf of the National RSSDI. We have seen definitely one thing which is definitely increasing in this non-communicable disease era is diabetes. And the other, if you ask me, which is again on the rise, but we are somehow not talking about it or somehow trying to avoid it, is the liver disease. That is the non-alcoholic fatty liver disease. You'll be astonished that around 5 to 15% of the data says the Indian population is having a prevalence of NAFLD or maybe more. And then it is a bidirectional. मैं कहूँगा डायबिटीज़ NAFLD को बढ़ाता है, उसके रिस्क को बढ़ाता है और NAFLD से प्रोग्रेशन होके वो सिरोसिस में बदलता है और वाइस वर्सा होता है. तो जब NAFLD होता है तो इनको 2 टाइम यानी इनका रिस्क जो डायबिटीज़ का होता है वो 2 बार या 2 टाइम्स बढ़ जाता है. तो टू डिस्कस ऑन इट टुडे वी हैव एलीट पैनल विद अस. Let me welcome first Dr. Prabhakar sir. He is a senior consultant gastroenterologist and hepatologist, ex-principal of Osmania Medical College, consultant at Apollo Hospital, Telangana. Very welcome to you, sir.
Hello. Thank you, Dr. Faraz, for inviting me to join this panel. Thank you very much.
Pleasure is ours, sir. Let me welcome Dr. S. Somasekhar Rao. Again, consultant gastroenterologist and hepatologist, again from Telangana, Hyderabad, from Apollo Hospital. Welcome, Dr. Somasekhar Rao.
Thank you, Dr. Faraz. Thank you. Good evening, everybody.
And then let me welcome Dr. Arun Kedia, senior consultant physician and head of ICU Life Worth Hospital from Raipur, Chhattisgarh. I'm sure he is gonna do the moderation and then अगर आप चाहें तो सर इसको हिंदी में ले सकते हैं क्योंकि हमारे काफ़ी जो व्यूअर्स हैं वो हिंदी को प्रेफर करते हैं. तो over to you, Dr. Arun Kumar. Please, you can take it from here. Thank you.
So thank you Faraz for the kind introduction. और आज सभी दर्शकों को मेरा नमस्कार और डायबिटीज बाइट्स में आप लोगों का स्वागत है. हमारे साथ तेलंगाना से 2 गैस्ट्रोएंटरोलॉजिस्ट जुड़े हैं जो आज डायबिटीज और लिवर के संबंध को समझाएंगे और हमें काफ़ी ज्ञान देंगे इस बारे में डायबिटीज पेशेंट्स में लिवर प्रॉब्लम्स क्यों बढ़ती हैं और लिवर डिजीजेस डायबिटीज को कैसे अफेक्ट करता है. तो हमारे बीच में सीनियर पर्सन है डॉक्टर प्रभाकर सर. तो सर सबसे पहले मैं आपसे ये जानना चाहूँगा कि डायबिटीज़ पेशेंट्स में जब भी कोई प्रॉब्लम पेट संबंधित होती है और हम उनकी सोनोग्राफी कराते हैं तो अधिकतर पेशेंट्स में फैटी लीवर आता है. तो सर व्हाट इज दिस फैटी लीवर एंड हाउ डू यू सी दिस फैटी लीवर इन योर क्लिनिकल प्रैक्टिस. मतलब हम दर्शकों को ये समझाना चाहते हैं कि फैटी लीवर का मतलब क्या होता है.
Thank you very much, sir. I think I'll both speak in Hindi as well as English. Fatty liver. When you say fatty liver, simply for layman, we can say there is more amount of fat in the liver. That is simply called fatty liver. Now, this sort of fatty liver can come because of multiple causes. One of them, commonest cause is this alcohol. But here, when the person doesn't take the alcohol, it is called as non-alcoholic fatty liver disease. There are umpteen number of causes, but the commonest thing that we are going to discuss today is non-alcoholic fatty liver disease. So, accumulation of fat in the liver, especially hepatocytes, is termed as fatty liver. And how common is this problem? It is very, very common. As Dr. Faraz was pointing out, it is quite common. Almost up to 15 to 20% of our population is affected with it. And more importantly, when you take the subsets of these patients, even in diabetes, it's very common. But how both of them are interlinked, you can say it is linked directly. I can say the precursor is obesity. When the person is very fat, automatically this fat obesity, and we try to judge it by taking what's called body mass index. वो ज़्यादा है, then automatically the patient will develop early diabetes. This early diabetes may develop because of insulin resistance, that I think we'll discuss later. And number two, because of obesity itself and because of higher levels of these triglycerides and also there's fat accumulation. Now, this is the link between these two, diabetes, fatty liver, and in between the link between this insulin resistance. So obesity can lead to lots of problems, but this is the common link. Obesity can cause that is type 2 diabetes. It can cause insulin resistance, and subsequently, because of this, it will lead to fatty liver disease. There are certain cases where fatty liver disease can occur in absence of the diabetes also, but commonly diabetes is associated with fatty liver disease. It leads to more incidence of this diabetes. Diabetes is when person has got, what are the liver diseases that are very common? Most important is non-alcoholic fatty liver disease. Second one, there can be increased incidence of alcohol liver disease also. And there is little increase of cirrhosis of liver. So the link here is diabetes causes more proneness for NAFLD, that is non-alcoholic fatty liver disease or fatty liver. So this is the link that is there. We can go further, but depending on this, I can say for a common man, when diabetes occurs, the patient can develop fatty liver disease also, which is double that of the common population.
तो बेसिकली सर का कहना है कि डायबिटीज और फैटी लिवर में आपस में दोनों में रिलेशन है और ये रिलेशन एक दूसरे के साथ जुड़ा हुआ है. तो डायबिटीज फैटी लिवर को बढ़ाता है और फैटी लिवर अपने आप में डायबिटीज के इंसिडेंस को बढ़ाता है टू द एक्सटेंट कि ऑलमोस्ट 1 in 5 मतलब 5 में एक पेशेंट अगर डायबिटीज है तो उसे फैटी लिवर होने के चांसेस हैं. और फैटी लिवर जो कॉमनली अल्कोहल से होता है, उसके अलावा डायबिटीज इज अ सिंगल मोस्ट कॉज जो कि नॉन अल्कोहलिक फैटी लिवर डिजीज का कारण है. और इन दोनों के बीच में सर ने समझाया बहुत अच्छे से कि ओबेसिटी इज द लिंक. और साथ में सर ने एक टर्म यूज किया था जो कि कहते हैं इंसुलिन रेजिस्टेंस. तो डॉक्टर सोमा शेखर राव सर से मैं ये जानना चाहूंगा कि व्हाट इज इंसुलिन रेजिस्टेंस. इंसुलिन रेजिस्टेंस को अगर आप कॉमन मैन को समझाना चाहेंगे तो हाउ विल यू ट्राई टू एक्सप्लेन इट.
See, most commonly, insulin is the thing which controls our blood sugar, and it is secreted by the pancreas. But to understand in simple terms, I would say your body is not responding properly to the insulin which is normally secreted by the pancreas. So the insulin is not working properly in your body. This is insulin resistance to common in simple terms. But why this happens? Because of multiple reasons, most commonly obesity. Because of increase in weight, your insulin will not be able to enter the cells because of this insulin resistance, and this will increase the sugars in your blood. So most commonly it is obesity which is causing this. And in India, unlike in Western world, not just the BMI, what we see most commonly is a truncal obesity. There is a lot of fat accumulated around the belly and around your organs. So not just BMI in India, it is truncal obesity. For example, if I say more than 40 inches of waist in men and more than 36 inches of waist in women is directly proportionate to your insulin resistance, and then diabetes or fatty liver or all complications of diabetes. I think
So I think you have very well explained about what is insulin resistance. So just to simplify it, basically जब आपके शरीर में इंसुलिन की सिक्रीशन होती है बट वो इंसुलिन की प्रॉपर यूसेज नहीं होती है, या जो सेल्स इंसुलिन को यूज करते हैं ग्लूकोज को यूटिलाइज करने के लिए वो प्रॉपरली इंसुलिन को यूटिलाइज नहीं कर पाते हैं, तो उसे हम इंसुलिन रेजिस्टेंस कहते हैं. और जैसा कि सर ने कहा कि सबसे बड़ा कारण इंसुलिन रेजिस्टेंस का है जब आपके बॉडी में फैट सेल्स बहुत ज़्यादा हों. तो ये फैट सेल्स ही आपकी बीएमआई को भी बढ़ाते हैं. और कुछ पेशेंट्स में बीएमआई नॉर्मल रहे या थोड़ी सी अबव नॉर्मल रहे, लेकिन फिर भी यदि आपके सेंट्रल ओबेसिटी रहे, अगर आपके बॉडी में मैक्सिमम चर्बी आपके बॉडी के सेंटर में एक्यूमुलेट हो, तो वैसे केसेस में भी इंसुलिन रेजिस्टेंस डेवलप होता है. और ये इंसुलिन रेजिस्टेंस आपके लिवर में फर्दर फैट एक्यूमुलेशन को बढ़ाते हैं, एंड अगेन व्हाट रिजल्ट्स इज अ फैटी लिवर. सो इसी तरह से डायबिटीज और फैटी लीवर में एक बीच में लिंक होता है, दैट इज इंसुलिन रेजिस्टेंस. सो कमिंग बैक टू प्रभाकर सर, most of the patients who present with fatty liver to you, what are the usual signs and symptoms that these patients present with?
इससे पहले मैं लिवर डिजीज कैसा मैनिफेस्ट होता, यूजुअली ये फैटी लिवर एंड डायबिटीज में देयर इज अ लिंक. ये हर एक पेशेंट को नहीं आता, बट देयर इज अ कैटेगरी ऑफ पेशेंट्स, ए कॉन्स्टलेशन ऑफ सिम्टम्स. 4-5 सिम्टम्स है तो इन लोगों को मेटाबॉलिक सिंड्रोम बोल के एक एंटिटी क्रिएट करें. ये मेटाबॉलिक सिंड्रोम में सबसे पहला ओबेसिटी, ऐसा सर पॉइंट आउट करे सो है, ओबेसिटी कितना है, एंड मोर इम्पोर्टेंटली आप पॉइंट आउट करें सो सेंट्रल ओबेसिटी और ट्रंकल ओबेसिटी, फैट अराउंड द एब्डोमेन. द सेम थिंग इट गोस अराउंड द विसरा. सो ओबेसिटी, then fatty liver disease, and most importantly the blood, there is increased levels of lipids or fats, that is cholesterol and triglycerides. Important thing is triglycerides are very, very high. And regarding diabetes also, it can be fully manifested with diabetes or they can present with insulin resistance. So in this metabolic syndrome that is there, the patient have a constellation of symptoms called blood pressure ज़्यादा रहता है, hypertension, obesity, ज़्यादा lipids, especially triglycerides, and fatty liver disease. These are 4-5 things that you should keep in mind where this metabolic syndrome can present. And these are the persons who are presenting with NAFLD. Some people also say, what is NAFLD? Mane fatty liver kya hai? Is English metabolic syndrome. So hepatic manifestation, this is one component of that one. So how do you detect fatty liver disease in a general population? And unfortunately, only when you have this constellation, you can suspect and think of it. About 90% of the patients with NAFLD are asymptomatic. They do not present with any symptoms. But suppose in the 10%, when the disease becomes more advanced, they can present with signs and symptoms of liver disease. This doesn't occur in all the 90%, but in 10%, what you can see is one of the common things when people implicate a liver is this jaundice, number one. It may not be present, only 10% can get. Number two, it can present with fluid accumulation, either fluid in the legs, that is pill edema, or fluid in the abdomen, ascites. Number three, easy bruisability. Number four, itching. So these are the signs of liver disease that you should keep in mind. All signs of liver cell failure. But 90% of them, they do not present in that one. Suppose such a patient comes to physician, how they are going to suspect? When the physician takes the whole history, very good history, and if the patient has got, let us say, he is a diabetic, he is hypertensive, he has got hyperlipidemia, he is obese, then definitely you should suspect the patient is also having some fat in the liver. How to go about it? Clinically, when he examines, he will find enlarged liver. Isko hepatomegaly bolte. So when you are palpating a liver, that too asymptomatic, you can see liver also is enlarged in this patient. Another test that is there is you can go for ultrasound. Ultrasound will show hepatomegaly. So उसमें different categories there, but hepatomegaly is one feature that is there. What is the type of hepatomegaly? What is the echo texture? Fluid है इनमें? ये ultrasound में मालूम हो जाएगा. Then simultaneously, when you are suspecting, थोड़े test करते, liver function test बोलते, all enzymes related to the liver. And in these liver enzymes, especially 2-3 are called AST, ALT, or a GGT है. So most important for us is AST and ALT. When they are normal, that is one category, or when they are abnormal. In that, bilirubin also will be done. So for NAFLD, hepatomegaly by ultrasound and elevated liver enzymes indicate that the patient is having liver disease. But 90% of them, you have to only suspect. And who is the person? Is it the hepatologist who is going to suspect? Or it is a primary physician? Basically, because diabetes is prevalent all over, it is the most important person who is going to understand it and also detect is primary care physician. He is the person because the patient goes to him regularly for all the problems. So when the patient is being evaluated and he sees an obese individual, he has got blood pressure, he is middle-aged, and he has got diabetes and he has got triglyceridemia, he will also suspect NAFLD. Then he will ask the specific symptoms. Then he will categorize. So एक बार वो symptoms है, then he will proceed in a different way. When symptoms are little out of proportion, then that is the time he will refer the patient to hepatologist or a gastroenterologist for further workup. Otherwise, usually he will follow up and see what are the things and what are the advice he will give. Advices are when to give medication and what are the lifestyle changes that is there, what he will advise the patient. So these categories of primary care physician is the most important person in the management of NAFLD in a diabetic. That is my perception. Who detects it is the first important. He is the first person to suspect it. Once he suspects it, in primary early stages, he only will treat it. In more advanced stages, then he will take consultation with the hepatologist or refer to the hepatologist for further workup and how to go about it. For other complications, I think we'll discuss later. But just to summarize, primary care physician is the one who is going to suspect whether he has got disease or not, is symptomatic or asymptomatic. If it is asymptomatic, how we will treat by simple test. At least for NAFLD is the ultrasound abdomen and liver function test. There are umpteen number of tests, but I don't want to confuse. For any ordinary person, what you can say is clinical examination में liver enlarged है या नहीं. And advanced disease में है तो jaundice, fluid, ascites ये पूरे पेट में है या नहीं देखते. Then fourth important thing is ultrasound and liver function test. Then further we will progress. That is what I would like to mention.
So, you have rightly pointed out that almost 90% of the patients will remain asymptomatic in the early stage, and that is why it is often missed and it is taken very lightly even by the patients. तो पेशेंट्स फैटी लिवर की डायग्नोसिस को बहुत हल्के में लेता है क्योंकि उनको इनिशियल फेज में कोई सिम्टम्स नहीं होते हैं और ज़्यादातर मरीज इस चीज़ की सीरियसनेस को समझते भी नहीं हैं. बट इट हैज़ टू बी रिमेंबर्ड और ये आपको सबको पता होना चाहिए कि फैटी लिवर अगर कंट्रोल नहीं करते हैं तो वो प्रोग्रेस करता है. और जैसा कि सर ने कहा कि एडवांस स्टेजेस में जब वो प्रोग्रेस करके सिरोसिस में आता है तो कई पेशेंट्स को जॉन्डिस डेवलप होता है, कई पेशेंट्स के पेट में पानी भरने लग जाता है, पैरों में सूजन आती है और वो कंडीशन फिर एंड स्टेज लिवर डिजीज तरफ चली जाती है जो कि काफ़ी घातक होती है. और वहाँ पे फिर अपने पास कोई विकल्प नहीं होता है क्योंकि तब तक हम रिवर्स कर नहीं सकते हैं फैटी लिवर को. एंड मोस्ट ऑफ द पेशेंट्स विल लैंड अप ईदर इन लिवर ट्रांसप्लांट or they may develop some complications which may result in death. So coming back to Soma Sekhar sir, as sir mentioned that there are certain tests that can be done for diagnosing liver disease. So would you like to throw some light on the common liver test and how we should approach these liver function tests in patients with diabetes who also have a fatty liver on an ultrasound?
Just before going to the investigations, I would like to add a few more points to what Dr.
Sure.
Prabhakar sir has said. Symptoms which are ignored most of the time are because the fat builds up on the liver and it presses or gives increased pressure on the liver capsule. Most of these people will have some persistent nagging right hypochondriac pain, which is often ignored by the patient and by the physician also. Maybe this is one symptom which we have to take into point. And second thing is, in these diabetic patients, even when the sugars are well controlled, these people will be complaining of tiredness and weakness. This have to indicate and probe the physician to investigate about liver disease in all these patients with high risk factors like diabetes and obesity. And when we are talking about investigations, most important investigation, as sir was saying, is liver function test. In that, your SGPT and SGOT, ALT and AST levels are more important. Elevated SGPT and SGOT, sometimes associated with GGTP, is an indication that the liver disease is progressing. And when you combine a CBC, a little mildly decreased platelet count is again indicating that these people are going into advanced liver disease. So any patient who is diagnosed to have fatty liver on ultrasound, and along with that, every ultrasound should be specifically measuring the size of the spleen in these patients with fatty liver. If you see any increase in the size of the spleen, it is again indicating it is early portal hypertension, that these people with fatty liver are prone to progress to cirrhosis of liver. So not all patients with fatty liver will progress to cirrhosis, but there are few points which we can take into consideration and start evaluating them in early phase. As I said, one is platelet count on CBC, SGPT levels, and splenomegaly along with fatty liver on an ultrasound. And when you suspect, when you see all these things, or when you are suspecting that the LFT, any of these things are worsening, now previously we used to do a liver biopsy to confirm the disease pattern and all. Now we have something called a fibroscan, which is widely available everywhere, where we will be able to have a cap score in a fibroscan, which says the amount of fat deposited with a number. So obvious patient also will be able to see the number and know that he has lot of fat. And there is something called median stiffness score, or KPA, which says whether the liver is becoming stiffer than normal because of the fat accumulation. These are the most important things at an initial stage, which can be done anywhere in the country. So with these things, we will be able to identify early stage of NASH, non-alcoholic steatohepatitis, progressing to non-alcoholic fatty liver disease and cirrhosis of liver. So if we are able to identify these patients in an early stage, obviously we will be able to reverse them also. So identifying and diagnosing at an early stage plays a very, very important role, and these investigations will help us to do that.
So, Dr. Somasekhar sir, you also come across many patients who come to you with fatty liver, but when you do a liver function test, it may be absolutely normal.
Exactly.
You may have a very normal bilirubin level. You may have patient with normal SGPT, SGOT level, and all the parameters are by and large normal. But only parameter that you see on ultrasound is a fatty liver. So, how do you approach these type of patients?
Most important thing here is we should be able to warn all these patients that at least 20 to 25% of them will be progressing to cirrhosis at some point of time. Even if they are normal at this point of time without much symptoms and LFTs are normal, 20 to 25% of all these patients with fatty liver at some point of time may progress to cirrhosis of liver. So whenever you see them at an early stage, even without any other LFT changes or splenomegaly, it is a reversible disease. So we will be starting them, educating them and letting them know the importance of fatty liver and the importance of reversing this fatty liver at an early stage. So
So, I
lifestyle
think
modification
yeah.
is the only suggestion what we do: dietary variation, dietary modification, and regular exercise.
So the message that Dr. Somasekhar sir wants to give is that even with a normal liver function test and with fatty liver, around 10 to 20% of the patients might progress to a chronic liver disease, sometimes even to the extent of cirrhosis. So these patients need to be followed up, and these patients must be educated about the follow-up tests also subsequently, maybe at interval of 6 months. You must repeat a liver function test, or maybe if the patient is symptomatic, then probably we might have to do early liver function test on a priority basis. Soma Sekhar sir also mentioned clearly that if you detect fatty liver in the early stage, then we must educate the patients about reversing. So he was using this word reversible. So, Dr. Prabhakar sir, would you like to throw light on what is
Yeah.
reversible fatty liver disease?
Yeah. As Dr. Somasekhar has pointed out very clearly, we have got stages in the progression of the liver disease. The maximum, what we are talking about, NAFLD, NAFLD, non-alcoholic fatty liver disease. This is the one where there's only pure accumulation of fat in the hepatocytes. So if in such cases, when you take a biopsy also, what you find here is liver hepatocytes filled up with the fats. Then next stage, what happens? This is the first stage, injury, because there's accumulation of triglycerides and also fat. This stage is highly reversible, and at this stage they are asymptomatic and they do not cause any harm to the patient. But next stage comes, not all, about 25%, as he told, go in because no body recognizes that something is wrong with that one, and there is injury. Now, inflammatory cells go and start attacking that one. That leads to inflammation. When there is inflammatory attack going on, it leads to hepatitis. Because there is fat in that one, it is called steatohepatitis. A easy name for that to remember is NASH, non-alcoholic steatohepatitis. This is second stage. This is now second attack has come. Now, when a lot of injury is going on, inflammation is going on, the body tries to fight back, and there is some of the cells will die, and this is replaced by next stage, what is called fibrosis. Fibrosis is now the liver becomes little stiffer and tougher. So this is the stage where there is cirrhosis. Then not cirrhosis, fibrosis. Then next stage comes what is called cirrhosis of liver. Cirrhosis is the liver cells also get damaged. There is fibrosis, and this is the final stage where, when it leads to this cirrhosis, the reversibility is not there. So from NAFLD, that is NAFLD to NASH, it is first step that is going to be there. And when such a thing occurs, we can reverse it. This is a reversible stage. When you can remove the fat from that stage, everything reverses. When it leads to fibrosis, still it is possible when you do more advanced interventions. But from fibrosis going into cirrhosis, mostly it is not reversible. That is a stage where you have gone out of it. So NAFLD, what are the problems that you are going to face? One is NASH, still reversible. Then it can lead to hepatic fibrosis. Then after cirrhosis of liver, which is very dangerous condition, because the only answer for that is in proper way is transplantation. Or some of them, because of the changes that are there, can lead to cancer of the liver, that is hepatocellular carcinoma. So this is another one that you have to keep in mind. Hepatocellular carcinoma and cirrhosis of liver, these are the two which are almost end stage, which can lead to death. This occurs only, as Dr. Somasekhar was pointing out, less than 10% of the cases. And that too, this progression will take almost 15 to 20 years. So again, in my previous, what I was telling is how you are going to recognize it, at what stage you are going to have it. So primary care physician is the one who is going to regularly examine, and every 6 months you will see. A stage comes when he sees ultrasound, he sees that hepatomegaly is there. Now suddenly the spleen also starts becoming little larger, or the echo texture changes. Then you will, and the liver enzymes are definitely, especially SGPT and SGOT, both are elevated. That is 240 is the cutoff point. Then for further evaluation, this ultrasound is not a marker. Ultrasound cannot detect it is fibrosis or cirrhosis. Maybe some markers will be there. So for that, the most important test, which I also follow regularly, is use the fibroscan, which is easily available, which is non-invasive. Before that, to make a diagnosis, liver biopsy was a must. People will definitely be afraid of doing liver biopsy for mild asymptomatic condition. But once you have this fibrosis, you will know what is the amount of fat in that CAP score and amount of stiffness. This stiffness is called fibrosis. The cutoff point usually we take as 7. Anything more than that one, now the patient is aware, and also doctor also is aware. This person is now going for more advanced disease. So a cutoff point as 7, if you take for KPA, then we want them. See, now we are going from NAFLD to NASH. From NASH, you can go to hepatic fibrosis. So you got in fibrosis also, you got F1, F2, F3. F3 is the most advanced one. So more, we get sometimes 30, 40 also, where we say we have to do some interventions, maybe transplantation. So this is the stage where with fibrosis you can evaluate and come to a conclusion. Now you asked about reversibility. As long as the patient doesn't have significant fibrosis that is more than F3, and it is F1 and F2, weight, diet, and weight reduction. When you can reduce the weight, automatically the fat disappears. Some studies have been done which showed, if, for example, they stand at your 80 kgs individual, because most of these persons are obese. If you do 5% weight reduction, 5% weight reduction is roughly around 4 kgs. Then all the fat that is there disappears. But if you can achieve or reduce by 8 kg, that's 10% of your body weight, even that fibrosis also sort of reverses. So this has become almost like a magic shit. 5%, 10%. Up to 10% you can reverse it and reduce. All these things are still reversible. That's the most important point that is there. The other question that comes is how long you are going to sustain it, whether you can sustain it for long. The question is, there are lots of people who have sustained it, but within 2 years, once they become careless about that one, it can reverse back to the original weight. But the important point is This is a reversible condition to a certain stage. That is, when there is F1 fibrosis and there is NASH also. But it goes beyond that one. Reversibility is not there. Even diabetes also, in some cases, now you can reverse the diabetes or you can cure the diabetes. All this is based upon weight reduction and also reducing the weight. This is the key point that is there. Lifestyle modifications, what they are there, what is the diet, what is the exercise, how much weight you should reduce. The whole crux moves around this point, how much you can do it. So this
So
point
the good news is that fatty liver is reversible if detected at an early stage, and
yes,
it behaves similar to what we call as reversal of diabetes. Similarly,
yes,
we can have reversal of fatty liver, and I think the pathway to reversal of fatty liver and reversal of diabetes is almost similar. And as you have rightly pointed out, it is a lifestyle disorder, and to certain extent fatty liver can be reversed only by managing and correcting a lifestyle, and try to incorporate a good diet and good exercise into our regular lifestyle so as to decrease the fat content of the body. So moving on to Dr. Somasekhar sir, what are the recommendations that you would like to put forward with regard to diet as well as for exercise to all our spectators today?
In simple terms, I would say it's a very easy thing. You should be doing at least brisk walking for 1 hour a day, at least for 5 days in a week, and cut down on excessive. I mean, it's a diabetic diet again. There is no much variation in the diet what we suggest for exclusively for fatty liver. It is only the diabetic diet. Cut down the excess carbohydrates, good amount of protein in your diet, cut down the excess oily and fatty foods. This is a normal diet what we suggest for any diabetic for reversal of fatty liver disease. And healthy weight loss is what we suggest. Abnormal weight loss by completely avoiding foods and all is going to further worsen your liver. Please remember this. It will further cause accumulation of fat in the liver. So it should be a healthy weight loss by regular exercise, whatever exercise you prefer to do. At least minimum thing would be a 45 minutes to 1 hour brisk walking every day for 5 days a week. It can be anything like cycling, it can be anything like playing a game which you like, but it should be for 1 hour in a day. And diet is exclusively same like your diabetic diet, and healthy weight loss is what we suggest. Definitely fatty liver is reversible with by following these lifestyle modifications.
So I think a 10% weight reduction would be recommended to most of the patients in order to find a significant change in fatty liver. So that is what I feel that we should recommend to our patients. We must refer them to a good dietitian and a lifestyle modification therapy in order to bring about at least 5 to 10% weight loss, so that it would help also in achieving a good glycemic control. At the same time, it would help them to reverse their fatty liver and thereby reduce the risk of progression to a chronic liver disease. So the next thing that comes to our mind whenever we say non-alcoholic fatty liver disease, there is a word called alcohol. And most of the patients, in our day-to-day practice, almost 40% of the male patients would always ask, sir, how much alcohol is safe and how much can we take on a weekly basis or on a daily basis? So any particular recommendations or any particular advice with regard to the consumption of alcohol that we need to give to these patients? Prabhakar
Uh,
sir.
yeah, both of us have definitely got some ideas. I'm sure also will tell it. From my point of view, what I follow here is the term non-alcoholic fatty liver disease, how that has come. And there is an equal term that's called alcohol liver disease. So the question that comes is, who is an alcoholic, who is a non-alcoholic, who is a social drinker? These are the words that we use very commonly. When some person takes a little alcohol and it is not causing much damage, we sometimes use the word called so-called social drinker. Social drinker is once in a while, occasionally, but the friends he will take it. When you will say a person is alcoholic, when he's taking very high amounts of alcohol, the we'll not go into very specifics of that one, but one thing, how much amount of alcohol is equal to that one? We have got different types of alcohol. We have got beer, we have got whiskey, we have got spirits, we have got wine. So many are there. Beer, for example, is the lightest one. If that's 3 to 5%. Then whiskey that is there, usually around 40%. Spirits can go up to 80 to 50%. It is the amount of alcohol rather than the concentration that is there. Wine, for example, is around 10 to 12%. So 1 unit of alcohol. So a male, if he takes around 40, that is 2 units. 1 unit, you can say 10% in that is 100 ml. Whiskey, if you take whiskey, 30 ml of 40% whiskey is almost equal to 1 unit. So a person, healthy person, is well nourished, he can take 2 units per day. Whereas for females, it is only half of that one. Anything less than that one is socially acceptable and is not supposed to cause any injury. But in my opinion, once the patient has got this fatty liver and other thing, even that amount of alcohol is going to cause some injury. But because this discussion is on the Western population and also Indians, everybody takes it, we have to restrict them rather than stop them totally, because nobody is going to stop it. Those are prone to take that one. Once there is disease, no alcohol should be taken. So by and large, for females, 1 unit per day, and for males, it is 2 units is permissible per day. Or what some people say is 14 drinks per week is the cutoff point. Because some people, what they will say is, we will not drink for 4 days, then next 3 days we will drink like anything. This is what is called binge drinking. Binge drinking also is very, very harmful. So per week, if you less than 10, but in single day it drinks more than 5, that also is very injurious. So the restriction is what you can say 2 drinks per day. I think that sort of answers that question. But the question that arises is, can you restrict them? What are the binge drinking? Can it cause injuries or not? And simultaneously, because we are talking about diabetes and cardiac diseases also, some papers have also come saying that wine is supposed to be quite useful. It is also helpful for the heart and other thing. Here, I'd like to go back. In all the types of diets that you have taken, Western population, they have studied a lot. We have got our Indian population, we have got South Indian, North Indian, different types of diet. The one which is best studied and found to be most useful cardiovascular disease-wise and also diabetes is Mediterranean diet. What is this Mediterranean diet? It is supposed to be very, very rich in vegetables. The oils and other things, fat that are there, they take it in the form of actually what you can say fish oil. Omega-3 fatty acids are supposed to be very, very beneficial. There, olive oil also is supposed to be quite useful. So just keeping that in mind, and especially more importantly, you've got this walnuts, almonds, they are supposed to be quite useful in these cases. Keeping that in mind, definitely you have to keep in mind, this is a diet, Mediterranean diet is supposed to be very, very useful. There in Mediterranean diet, they allow wine, but not other spirits. That is a point I'd like to just stress. And more importantly, some people have shown coffee. Is coffee going to be helpful? Peculiarly for non-alcohol fatty liver disease, coffee has been that is very, very useful in NAFLD cases. That is fatty liver. Not the regular coffee with milk and sugar. It should be a black coffee. Even decaffeinated also is quite okay. 2 to 3 cups of this coffee is very helpful for non-alcoholic fatty liver disease. Regarding the diet, more importantly, I'd like to tell you, weight reduction, 5% also has been found to show that fat will disappear totally from the liver. When you reduce by 10%, that is, I told you 80%, 8 kgs, even that fibrosis also reverses. So that is a very important point. So little amount of weight reduction, dieting, and most importantly, exercise. Exercise also, they have the best and easiest exercise is brisk walking. That is, everybody is possible. And where they want to reduce, they can do this isotonic exercise also, and also weight-bearing exercises. That will be useful. But for ordinary people, brisk walking is supposed to be the best. Doesn't require any preparation. At least minimum 45 minutes per day. If they do it, it is very, very useful. These are the lifestyle modifications I would like to advise. So the most important diet what you should eat lots of greens. Then what about non-vegetarian? Fish is supposed to be very good. Then next after that one, poultry, eggs also are there. As far as possible, try to avoid red meat and big meats. That's very important. Alcohol and beverages, I told you, as far as possible, try to avoid. But one which has been found to be useful is supposed to be wine, especially for cardiovascular diseases. Here, in a different way, I would like to say, suppose fat liver is there, it is not causing any harm. What damage is there? We can tell most of the people, once there is fatty liver, NAFL, very early, within 2 to 3 years, they are going to develop cardiovascular disease. So it is a sort of marker for early cardiovascular disease in most of these patients. At least the patients, they are a little alert when they say they are going to develop cardiovascular disease, especially with NAFL. They are going to develop very early. This is the point
So I
I would
think
like
your
to.
message is very clear, sir, that once
Yeah.
you have a fatty liver disease, it is mandatory that we try to avoid alcohol. On
Yes.
one hand, alcohol would superimpose alcoholic fatty liver disease over the non-fatty liver disease. On the other hand, alcohol always predisposes diabetic patients to also hypoglycemic episodes, and that is
Yes.
why alcohol may not be a good advice to most of our patients who have diabetes with fatty liver. So, as you have already explained about a good dietary intervention, a good lifestyle intervention in terms of brisk walking, there is another new update that for a good weight loss, we must also avoid a prolonged sedentary time. So, what has been recommended is that the patient should not be sedentary for more than 30 minutes at a time. So, this message we should give to all our patients, that after every 30 minutes of being sedentary, they should try to get up, move about. Post meals, they should move about so as to maintain a good weight loss. And moving on to Dr. Somasekhar sir, would you recommend any treatment, or do we have any drugs for fatty liver? Because most of the patients would also demand treatment. We can also give them all these advice, but they want some drugs. So, a brief note on any drugs to treat fatty liver.
Yeah, when we are talking about, as Dr. Prabhakar sir has told us, stages or grades of fatty liver. When we are seeing only fatty liver on ultrasound and we don't see any other abnormalities in liver function test or a splenomegaly, generally there are no medications which are approved or which are going to be useful in reversal of this diabetes. So we don't suggest any medications at that point of time, definitely. But there is a next stage called non-alcoholic steatohepatitis, where the liver function test starts becoming abnormal and SGPT is elevated. There are like 46 drugs which are still under, they are still being studied. Most of them are in phase 3 trials and all those things. And recently in India, definitely, we have saraglitazole, which is still in phase 3 trials, but most of us have the experience with saraglitazole. It is reversing the LFTs to normalcy again in all these patients with non-alcoholic steatohepatitis. We have studies of more than 15,000 people, which is available today in India, and most of them, at least 90% of them, there is reversal of SGPT in these patients, but it is still to be approved by FDA and DCGA for this indication. It is approved for hypertriglyceridemia, dyslipidemia, as all of you know, but approval for NASH is still pending. But still, we can as well prescribe, because most of them are diabetics. When these patients with NASH are diabetics, definitely we would suggest a prescription of saraglitazole for 3 months, 4 mg, which is helping.
So I think your message is very clear. Okay, as of now, we don't have a very clear-cut therapeutic, drug for treating fatty liver specifically, but we have certain drugs which could target the pathophysiology in terms of using certain markers. So I think Prabhakar sir and Somasekhar sir, both of you have tremendously and very nicely in depth explained about the liver diseases that are common in patients of diabetes. And I thank you for giving a good insight into this topic to all our audience today. And I thank RSSDI Diabetes Bytes Social Connect for this opportunity, for bringing us all to this platform to discuss about diabetes and fatty liver. So I hand over back to Dr. Faraz to summarize today's session and to just give a brief message that our audience can take as a summary of today's talk.
Yeah, so let me first thank all of you for that wonderful explanation. I think it's been very crispy, and then I had all my ears to it. Thank you so much, Dr. Prabhakar ji. Thank you so much, Dr. Soma Sekhar, and then of course, Dr. Arun sir. You've done an excellent, marvelous job. I think the good news we already knew was yes, diabetes is reversible, but at an early stage with a correct lifestyle and healthy modification of the diet. But the great news is fatty liver is also reversible. So I think most of the time we do get patients at an early stage where most of the diabetic patients do have fatty liver. तो यहाँ पर आपको एक बहुत ही मैं कहूँगा इम्पोर्टेंट न्यूज़ आज पता चली है कि आपको घबराना नहीं है, प्रॉपर डाइट को फॉलो करना है, वेट लॉस को करना है और वेट लॉस 5 to 10% इन अ फेज्ड मैनर. आई थिंक ये भी बहुत इंपॉर्टेंट है. ऐसे नहीं है कि आप क्रैश डाइट करके एक ही महीने में आप 10% आपका वेट उतार दो, ये भी गलत है. सो फेज वाइज मैनर में आपको वेट लॉस करना है. तो आप ये नॉन कम्युनिकेबल डिजीजेस जो है, जिसका डॉक्टर प्रभाकर ने कहा मेटाबॉलिक सिंड्रोम, मैं कहूँगा मेटाबॉलिक सिंड्रोम का ढोल जो एक मेरे सीनियर ने कहा है, इसका ढोल पूरी दुनिया में बज चुका है, जो है डायबिटीज, हाइपरटेंशन, ओबेसिटी एंड डिसलिपिडीमिया. तो इस ढोल को हमें कम करने के लिए अच्छी लाइफस्टाइल को मेंटेन करना है, फिजिकल एक्टिविटी करना है और हेल्थी एंड फिट रहना है. So in the end, I want to thank each and all of you as well for joining us today for this show. Thank you and see you next week for in the Diabetes Bytes. Thank you. Stay safe.
Thank
you, everyone.
Thank you.